Could invite the panelists up, and let's see, we've got 2 extra chairs, so we'll probably need a few more. If you can bring them up with you. Thank you. And Ted, did we get any questions you want to start us with?
We have a few, a couple for, I think, during Matt and Melina's talks. One is probably, Matt, maybe you could field this. Our VR simulator needs to be replaced. The cost is significant. We approached GI and pulmonary to discuss a cooperative effort to spread out the expense to several groups. Their interest was limited. They said after 2 weeks, their fellows have reached a good level of skill and are doubtful that a simulator is necessary. So what do we tell somebody like that?
Yeah, you know, that's a problem that a lot of us face, and I think the real drive behind continuing to acquire simulators like this may be a program like FES, especially if it gets mandated. And we were talking about this yesterday in FLS, how the interest in pass rates and et cetera of the test increased significantly when the mandate came through. So, but it is hard right now to make that argument in terms of flexible endoscopy based on the literature that Melina presented in terms of spending a lot of money on a VR simulator for a lot of bang. But hopefully that will change, I think, as programs like this move along.
So again, I think it's a really good point, and the problem with a lot of the VR simulators out there is not that the simulators necessarily are bad. It's just that they have a whole lot of metrics associated with them that are meaningless. And so it's really hard to create a curriculum that has meaningful outcomes. Like when you get feedback of score like 527, it doesn't mean anything to you. Then it's hard to really advance and get better in these types of environments. So I understand what they're saying, and certainly that's what the data suggests, is that this is really has a limited usefulness in the very early stages of someone's training, and so is it worth that investment if it's only going to improve performance in the first 15 cases? And I think that's what we're really, we did put a lot of effort into the creation of FES, and the bottom line is that it is feasible within a virtual reality interface, but certainly most of the stuff out there hasn't yet been developed to really, I think, be able to fulfill the potential that it could have from an educational standpoint. And certainly I think there's a lot of work to be done in that area. Is it not worth the investment at this point? I think, given the things that we have, certainly it's worth the investment if you want to become an FES test center, if you want to, is that something that's important to you? But if you want to just use it for a training tool, I think a lot of the work still needs to be done in terms of developing meaningful curricula.
Ted, can I make a comment?
Absolutely.
So I would actually take a little bit of the opposite stance. We've had a VR simulator for flexible endoscopy in programs for some time, and I would say I think the frustration people get is they have an expectation that the thing's over there and you just go and use it, and if you're expecting that to be how it's to be used and make people better, then you're right, you're going to get frustrated. It's not a very useful tool that way. So the way that I've seen it and the way that I've used it to be useful across platforms is you use it intermittently through different parts of the experience. So for instance, in our program, if you are a second or third year resident, you must demonstrate a minimum proficiency in the game environment on the Symbionics. So you have to do endobubble 1, you have to pop all the bubbles, not touch the side, 2 minutes or less. That's our proficiency. And you're not going into the GI suite until you can do that. So then they get some basic scope gymnastics. Later in their experience, now I got to come in and I got to spend time with them. And it's kind of like you were talking about, Melina, with the data, where it doesn't just work to do it alone. But for upper GI bleeding, for instance, I find it very powerful. I pull up the simulator, I get an ulcer, the blood's pumping away, and now we're going to talk. What tools, what energy settings, how are you going to approach this? If it doesn't work, what surgical intervention are you going to do when I'm with the surgical residents? And even for ERCP, you know, they're a little kind of jumpy for doing ERCP, but for demonstrating this is how you get into short position, these are the strategies, this is why you do that. If you're there next to them, it can be quite a powerful tool, but it can't just kind of be, go do something on the simulator and expect it to make you better.
Brian, I think you hit it right on. Like, that's the whole point. But I guess my question is, or the question that the people out there have, is that the impact that you have is you standing next to it. And if they had a scope inside a plastic balloon with, like, you know, red ketchup on it bleeding, they could probably learn the same thing. So do we need to pay $100,000 to learn that? It's that the value of that experience is your interaction with them, relating it to the clinical environment, having the back and forth, going out into the clinical environment, realizing what they don't know, and then coming back to the simulator and learning it. So, you know, I'm not sure about the value of the VR for that.
Second microphone.
Yeah. Eric Hungnes from Northwestern. Had a question about the logistics and the practical rollout of this. And with FLS, we had Danny Scott's and Matt's, you know, proficiency-based curriculum, so that we knew that when they achieved these parameters, that they were going to achieve 100% success rate on their FLS. And that was using the FLS model as practice, where this is going to be different. My understanding, you know, they're not going to be able to practice with the modules of FES. So are there going to be proficiency-based guides so that we know when our trainees can take the FES exam with success? And is that going to be part of the rollout with this?
Well, I mean, I think that's where some of these other tools are going to come into play. You know, you saw some of the things that you can use the step towers for example. When you actually play with the FES testing modules, you'll realize that they really do mimic the skills that you need to do endoscopy. You know, getting that little shape into that little that cutout is very much like torquing the scope into the right position to get the picture upright in a shoebox model, or to retroflex to look at something. They're very similar. And I think that, I don't have the data on it, but I think that those skills will translate into your ability to take that test successfully.
I just think it would be very helpful to have that up front,
Yeah.
To know that, because it's going to be different. They're not going to be able to train with the FES modules. And it's different it's a different paradigm than the FLS.
Yeah, we are trying to gather some proficiency scores for some of the step things.
You got to remember, when FLS was rolled out, Danny Scott and Matt Ritter's stuff did not exist. It took some time for that stuff to be generated. So I told you at the end, you have to be patient. I recognize that people are eager to sort of move ahead, but just the same, it'll take some time to generate that kind of surrogate evaluation. It'll come with time. People are eager and inventive, but you're not going to have it on day one.
And there are numerous modules out there, Eric, that probably will very well let you know along the way, you know, when your resident's going to pass this test with some confidence. And again, also with the curriculum, you know, as the curriculum rolls out, as people have gone through the curriculum with the didactics, with some of the hands-on skills that from STEP that go along with that curriculum, our expectations are that yes, there should not be a fail rate below that which we see for FLS when you're a chief resident.
It's a great point, though. It's a different paradigm, isn't it? You don't get the actual FES to practice on in order to pass the test. But we fully anticipate that there will be a number of platforms that will be correlated to success on the exam, just like what was done for the FLS curriculum. I think that's going to be STEP. I think it's going to be using a couple of models on STEP, maybe these physical models. I think you'll see Symbionics come out with practice platforms for FES. And it'll be up to us to do the validation, like what was done for the FLS curriculum, to say, hey, if you do this proficiency on this model, whether that's a physical model or a computer model, that predicts good success in FES.
And for those of you that are into education and assessment of skills, this is wide open for research. I mean, honestly, I think it is, as Brian said, something that a lot of people are going to take upon themselves to show some validation.
So maybe this one I can direct to Dr. Oregi. Despite good training systems and simulation, we surgeons have no time to do endoscopy in real practice. How can we overcome this limitation? Any suggestions for a practicing surgeon trying to get more experience in endoscopy, and how do they incorporate it into their practice?
You know, this is something I've been struggling with for 20 years. It really is. The practicing surgeon has a tough time. Those that are willing to do it usually do have fellows and residents. But I think the idea of I think somebody showed a slide there. There are surgeons in the rural areas that have good quantity. In fact, I think we were doing that. SAGES was recommending that for a while to find surgeons in rural areas who have a significant practice of endoscopy, and they're happy to help. I think that's probably the best thing for a surgeon to learn how to do upper endoscopy and lower endoscopy. Most of us that are doing the advanced stuff, ERCPs, EUSs, are already committed to teaching fellows and soon residents. So I think it's still a tough problem if you're out in practice, but my best recommendation is go to the rural surgeons to get actual hands-on, but visit us at the facilities and see how we do it. You know, I think all of us are happy to accommodate.
I think the best place is where you're comfortable, which is the operating room. I think that every bariatric surgeon should be scoping every bypass, every Nissen that's done should be assessed for adequacy of the wrap, every Heller, every colon resection you do. So I think there are lots of times during your operative day, you know, that you could throw in flexible endoscope in and start gaining some of those ideas and skills. So.
I actually tell my fellows that, you know, when they go to a hospital where they're not sure if they're going to have easy access to endoscopy, is volunteer to help out on the GI bleed kind of call schedule. Drag your endoscopist into the operating room to watch you do some endoscopy. Number one, they hate going to the operating room. So it's going to be no time at all before they say, yeah, you're fine to do this. And that's your first step in the door to finally get some more skills. So Brian, how many cases are needed for proper evaluation of training? It's one of the tweets we have here.
Does that have an ASGE label on it? So how many cases are required before you're kind of eligible to be evaluated?
Proper evaluation of training.
I'm not sure what the answer to that is. I mean, and the reason why I joked about ASGE is because they actually do have a minimum number based on an abstract that says that you are really not ready to be evaluated for your proficiency in endoscopy until I think you've done 130 uppers and 140 lowers, something like that. The data on that is very shaky. And I presented rather quickly some of the stuff that said, you know, it's probably closer to 50 uppers and 75 lowers, which is in the range that the gauges data said. So I think we really need to move away from numbers. It doesn't, to me, the numbers don't matter. We've all seen that when we've had people in training. Some people move through much quickly, some people don't. And so I think that the evaluation is ongoing, and what we should really focus on is what's the end game? What is the with a validated measure of evaluation, what's the level that you want to achieve? And I don't really care at what time point that happens.
So I have a question maybe to John or Matt. Should we be thinking about changing the way we train our medical students so that their last 3 months they're going to spend in these simulation environments to prepare them for whatever specialty they're going into?
Yeah, I think that's a great concept and one that I think you see more and more of. I'm a clerkship director for third and fourth year students at USIS, and you know, going to ASE and other places, there's a growing interest in these kind of end of medical student time boot camps where they do various simulations, either it'll be clinical type skills like refreshing, you know, history, physical, that kind of thing, and then some beginning immersion into skills. So I think we learned this with FLS and learn it as we go into simulation in general is once you have a good curriculum, you can push it down lower and lower, and especially for skills, for actual coordination type skills. I mean, there's no requirement to be a PGY anything. I mean, you can have that skill set in your toolbox early on.
I agree with Matt, and we have a resident readiness clerkship, we call it, that any senior student going into a surgical discipline takes in the latter part of their fourth year, and they found very valuable, and it includes basic technical modules like central lines, chest tubes, it includes some cognitive elements, it includes some teamwork elements. And they found it one of the more valuable medical student experiences. Many of you, perhaps all of you know that the ACS, APDS have been working on a national bridge curriculum, is what some people call it. Rebecca Minter from University of Michigan is in charge of the committee that's working on it. There may be people in this group that are on it. I don't know who else on the committee, but I think that issue of preparing people at the student level to be ready to launch into surgical training environments is a national area of interest, and we'll see more in years to come.
John, while you have the microphone, can I ask you a question along that same line? I'm sorry. I just want to know, I mean, so you're involved with Program Directors Society. I mean, should we really be training every resident in the surgical field in endoscopy? I mean, you know, is there going to be a point where we are going to have tracking, where we need to accept the fact that some people that want to go into breast surgery don't need to do flexible endoscopy? I mean, I know we keep pushing this down everyone's throat, but is that something that's in the next 10 years going to be something that we're going to be facing?
It's a good question, and I just listened to a debate last week at Central Surgical over the issue of tracking or non-tracking, earlier specialization of training to preserve index experiences for people that were really going to employ them. I personally feel, and I'd be interested in others' comments, that endoscopy is a skill that is really translatable across many surgical disciplines. And I can see thoracic surgeons, ENT surgeons, you know, people of a variety of backgrounds being able to benefit greatly from using a two-dimensional screen to navigate in a three-dimensional environment, being able to target some of the things that are brought out in some of the talks this morning. So I would see this as being one of those retained skills in a multidisciplinary curriculum, even if we start to differentiate or track earlier in how we train surgeons for economic and time pressure reasons. Melina, were you going to say something?
I was going to comment on something about the previous sort of pre-medical school or pre-residency training, and I think the important thing to remember about these things, however, is that the impact of it is also really dependent on people also getting exposed to the clinical environment and seeing what they don't know and then coming back. So having a boot camp is great at the beginning and they can learn some very basic stuff, but for it to be, I think, worth it, there also needs to be some time where they get to come back and rework some of that stuff and build on what they've already learned after being exposed to the clinical environment. So I think that it's great to do some of that stuff up front, but we want to sometimes believe that we can just like get stuff in and fit it in before something else starts, and unfortunately that's not the way the human brain learns. So that's it.
Wait, you know, before you run away, Melina, you want to stay at the microphone? I have a question for you. All this stuff that we've looked at for skills assessment, one of the things that I think, and maybe Matt can even talk about as well, is skill decay. You know, you go away, you get deployed, let's say, God forbid, you know, for 8-9 months, and do you come back? Is there something that needs to be in terms of an assessment tool that we should be creating as well, you know, that goes along the, you know, MOC kind of stuff, you know, in terms of proficiency kind of things? So has anyone done any VR stuff looking at skill decay?
VR stuff with skill decay. I mean, there has been work done regarding skill decay, and I think a lot of that has to do with work related specifically to soldiers who are deployed and stuff, so perhaps Matt can comment more on it. But I think these same tools that we're developing to assess competence, proficiency, these are the same tools that can be used, you know, once someone has had a prolonged period of time where they haven't practiced something. And it's clear that if you don't use it, you lose it. However, you know, it depends how much you were doing before and to what level. And so I don't know, that's a complex question, especially for, you know, endoscopy. But I think a lot of these tools that we're developing to help people acquire the skills are the same tools that perhaps can be done, you know, in a more protracted way to also help people train
I wonder if that'd be an interesting role for simulation. If simulation is only going to help in the first 15 to 30 cases, and that's all you've lost in terms of skill decay, you put someone on a simulation curriculum, does that get them back up to where they were before?
I think simulation is much more useful than for the first 15 cases. We just haven't figured that out yet.
Okay. Matt, I'm sorry.
Sure, yeah. You know, having deployed 3 times in the last 4 years, this is something that is very near and dear to my heart. But I also think there's probably more made of it than is real for the busy surgeon. If you're at that automated proficiency level when you leave, I think what you see is sure, if you do a one trial test the first day you walk back in the operating room, you're going to show skills decay. But I think most of the skills training literature would support the concept of spontaneous recovery, rapid spontaneous recovery, like we showed in the FLS retention data, that, you know, a very minimal kind of refamiliarization, if you're at the expert level before you leave, is probably all that's required. If you were on your learning curve before you left, I don't know. I don't think that's been answered objectively, but subjectively, you're probably going to start over.
So on that same vein, there's another tweet here we have. I've been disappointed in resident skill retention with regard to FLS. It's clear that continued practice is necessary for skill maintenance. What support is available for this in endoscopic skills, especially during residency when endoscopic cases are heavily dependent on rotations? So Jeff, do you want to comment?
I don't know. I mean, you know.
Maybe I should pick somebody else then.
No, well, maybe. No, I mean, the question is obviously is a good one. You know, and the funny thing is, so flexible endoscopy is one of 300, right? Is it 300? You know, different, you know, kind of procedures that we will assess during surgical residency training. So, you know, what about hernias? What about, you know, pancreatectomy? What, you know, I'm saying, I mean, all of these things I think apply to everything that we do in surgical training. You know, that if you don't, like Melina said, if, you know, if you don't use it, you might lose it. But I think it depends on what level you're at. If you're at an expert level, as Matt said, you may not lose it. That skill decay may be less so. So in terms of what support is available, I would tell you that we do, SAGES does run a lot of resident training courses. You know, in both advanced laparoscopy and endoscopy, that may be one avenue, you know, for your residents to continue if they're not on a rotation that allows them to stay with it. And again, it goes back to, I think, that almost every, other than being on a breast service, I can't tell you that flexible endoscopy can't really apply to every, you know, case that we do. And you just have to be creative and try to figure out how you're going to do that.
If I could just add to that, I think for our institution, once they finish their endoscopy rotation, whenever they rotate on any service in general surgery, if we're doing a bariatric case or whatever, I make them go and scope the patient, even though they might want to be the person squirting the anastomosis to see if it's leaking or not, because I think it's important for them to maintain that skill. And it's become sort of the standard now where the resident breaks scrubs to scope, not the other way around for most cases, because they do, and most of them do it voluntarily because they want to keep doing it. They do the pegs, they do all the intraoperative endoscopy. So I think there's, in most of the rotations, as Jeff said, there's opportunity for them to keep that skill up.
And I was just, I wanted to add to that. I think with minimum effort, you can find a lot of opportunities to keep doing endoscopy. And we built this into the curriculum, but that's in the OR. That's in the, don't forget the ICU, every peg, every feeding tube, that kind of thing. Colorectal surgery, I don't know why you blow air up there. Put a scope up there, take a look, make sure it looks good, you know, that kind of stuff. It's an opportunity. So I think that's an easy way to maintain skills. And I also would look closer within the institution. You know, in our institution, I have an endoscopy day. I would say that 70% of the time I'm doing scopes alone. And so those are lost opportunities for the residents. It's not that the residents got their feet up, but you know, there's stuff going on. So there's opportunity to do it. It does raise this question though about, does everybody need everything? And I personally am of the opinion that no. I actually think that surgical residencies should offer a flexible endoscopy curriculum selectively. Either I'm a program that offers it and you get a special little star on your certificate that says you're a surgical endoscopist when you're finished, or you're not, because it takes effort and you have to garner this stuff, and I'm not sure everybody needs to get up to the level of they can go out and do screening colonoscopy well when they're done.
On the other hand, though, I tell the residents, when I was training, the things I said I would never do is reflux surgery and obesity surgery, which is now 90% of my practice. So you just never know.
Yeah, that's true. Can I ask Sam a question? Sam, can you come? Where is that? He's not here. Never mind. Okay. I thought he was behind us. One of the questions, maybe the audience or you guys can answer. So we think there's not enough surgeons out there. Is it because there's a longer waiting list to get surgical procedures that we think it's that way? I mean, what exactly, you know, what does it matter, the number of surgeons that are out there? They're just doing more cases. Is the patient outcomes changing because of the number of surgeons? Is there any data to support that there's issues, not in Canada, but in this country, in terms of waiting times? Any comments? I'm just saying that, so you only have one surgeon in a 100-mile radius, all right? Is that affecting the care being provided to those patients in the sense that people are waiting for elective surgical procedures or having to travel? You know, does it matter that we don't have as many surgeons? John, I mean...
I don't know the answer, but I think one of the things, I think it was Sam alluded to in his talk, was Hiram Polk's paper. And I think many of us, probably many in the audience, if you practice in a more tertiary or urban environment, have found in recent years a trend where people are coming farther and farther to see you for routine surgical problems because of lack of access in a more rural setting. So I've had appendectomies come to me from 4 hours away, and I've seen more of that as a trend. And I think that's what his paper was highlighting that Sam mentioned, is that there's a more concentrated effort, and it correlates with volume as he showed in that slide. Oh, there you go. So Sam, can you come up here? So I think while the care may still be rendered, I think there are new stresses on both the patient in getting access to the care and providers having increased their volume to meet the care need. That's a reflection of the workforce. But Sam, can you repeat the question for
Sure,
him?
and maybe it wasn't worded terribly well, or maybe it's not well thought out. But Sam, the question I had for you, come on up. You get to come to the microphone. All right, you walk in the room, you go to the microphone. You know, is having a shortage of surgeons a problem? I mean, is it a problem in terms of how patient outcomes are occurring? Is it a problem in terms of patient wait times? You know, is there any data to support that we're not providing adequate care because we have less surgeons?
That's you know, I think there's several parts to that question. One of is in relation to endoscopy. You know, that there isn't a lot of data. There was a paper that was written that evaluated capacity for delivering endoscopy care and compared rural versus urban hospitals. In rural, where there's fewer surgeons typically, and actually the relative capacity was higher in the surgery in the rural hospitals, and the wait times were shorter. So it's complicated. The wait times aren't necessarily related to surgeon volume per capita. But could also have to do with the way that systems are set up. I think where not having enough surgeons creates a problem. I mean, clearly there are places where there are too many surgeons. Boston, maybe even. Although I don't want to volunteer to leave. But in rural populations or hospitals that serve rural populations, if they don't have a surgeon, it's not just about surgical care. It's not about endoscopy. It's not about surgical care. It's about the whole system because you know, hospitals depend disproportionately on surgical revenues to stay afloat, and there are a lot of services that can't be delivered when there's not a surgeon, say emergency care, biopsies, et cetera, and also then this has been studied when local populations or local people bypass or leave a hospital to get surgical care that they can't get locally, they typically take the rest of the care with them. You know, so they start seeing the cardiologist there or the internist there somewhere else. So the effect of a deficit in surgeon numbers is actually quite broad on a system, and particularly in rural areas.
Thanks. Any questions from the audience? Any other? We'll run out of tweets. Comments?
If not, let me just say thanks to the audience for your attention, and thanks to each of the panelists. I think they did an outstanding job of educating all of us, and appreciate the time and effort put in. Thank you.